This is chapter 46, the endocrine dysfunction. So the endocrine system consists of cells which send the chemical messages by means of hormones to the target cells or end organs. The target cells or end organs obviously receive these chemical messages via the hormones. And then the environment through which chemicals are transported, meaning blood, lymph, extracellular fluids. Hormone is a substance produced and secreted into the body fluids. There are many different types of hormones. If you go to your next slide, you'll have a picture of the endocrine system. This is a picture actually of the pituitary gland, and you see that it's divided into two lobes, the anterior pituitary and the posterior pituitary. And these are all the different hormones that it makes and controls and secretes. So if you have trouble with your thyroid, you'll probably have trouble with the initiating hormone or the thyroid stimulating hormone. If the child has trouble with growth, then they'll have issues with, most likely they'll have issues with the secretion of the growth hormone. Panhypituitarism is really a global type of deficiency in all these hormones. So disorders of the pituitary function, this can be due to any organic defects or any or have an idiopathic cause. The problem may involve a single hormone or a combination of several hormone deficiencies. And if it's several, again, if there are several hormone deficiencies, this is a panhypopituitarism. And of course, what the signs and symptoms really depend on what type of hormone is involved. As an example, if the child is not growing, then it's a growth hormone, as we previously discussed. If they're having issues with thyroid, then obviously it's a thyroid stimulating hormone. The disorder itself may result in an overproduction or a hormone deficiency. The first one we're going to talk about is hypopituitarism, or a growth hormone deficiency. And this is a deficient in the secretion of pituitary hormones, and it inhibits the growth and the development of secondary sex characteristics. And of course, depending on the degree of the dysfunction, how little of the growth hormone the pituitary gland is secreting depends on the outward effects. Of course, we are looking at the gonadotropin deficiency, the growth hormone deficiency, the thyroid stimulating hormone, and the corticotropin deficiency. These are, if you look on page 1463, you will see clinical, as we talked about, you'll see clinical manifestations of the panhypopituitarism. And this is when it takes a look at when each of these hormones is deficient and what the outward signs and symptoms are going to be. We're going to start off by talking about the growth hormone deficiency. And of course, you can get a lot of information just from the family history. All you have to do is really walk in the room and look at the mother and father. And if the child is there for failure to thrive, or not gaining weight or not growing, whatever the reason that they may give you that they're there, just look at the parents. And again, we're looking at the growth charts. Are very, very important in order to help this diagnosis. Especially if you've been the pediatrician, or you've worked as a nurse, you've worked in the pediatrician's office since the child's born, and you have a really good growth chart. And if the child is not gaining weight or not even on the chart, there's a reason for that. Or the growth is not even on the chart, there's a reason for that. But a lot of times you can go in and you can look at the parents. And if the parents have short stature, if they're not tall, you need to get that history. How tall are you, Mom? And she's going to say 5'2". And how tall are you, Dad? And he's going to say 5'5". Well, you know that those measurements are not tall, especially for a man and especially for Mom. So can we really expect this child to be 6 feet when he gets older. No, I mean, so obviously the history is very important. However, the converse can be true as well. I mean, if you have a really tall dad and a medium, regular sized mom, or a normal quotation mark normal height, and the child is just not growing, well, that will send up a red flag as well. And as far as the growth chart goes, a lot of times with these kids with growth hormone deficiency, they will grow very well for the first year. You might see them, born at 7 pounds 5 ounces and continue their growth, but then once they hit a year old, you're seeing them in the office at 3 and 4 years old, and now you're going to see a decline, or kind of like a parallel growth chart. And so that's when those red flags come up. We look at psychosocial evaluations. We can do a skeletal survey, which is a radiographic survey. And really what they're doing is a skeletal survey usually is a picture of the wrist. It's where, the epiphyseal center is. And you have a couple of different growth areas. But a very good one is where the hand and wrist meet. And they can measure that. And, if there's still some areas for closure, then that's good, because that means that the child is still going to grow. The growth plate has not closed yet, so therefore the child has a tendency to grow. If there's a delayed bone age, that's not so bad. It's not so bad as it sounds, because if the child is really small, then he still has time to make up for that growth. However, if the child is small and the growth plate has already closed, well, then there's some issues. If the bone age is normal, and as I said, and the child is still short stature, and the epiphyseal center has closed, well, then there may be some issues. Some endocrine studies that can be done. One in particular is something called the insulin-like growth hormone, IGF, and they can look at that to see if the child is secreting enough insulin growth hormone, and if not, then obviously they'll be referred to endocrinology. So the therapeutic treatment of the growth hormone deficiency is really directed towards the underlying disease process. Sometimes, depending on what's going on, the physician may order, or the endocrinologist may order, growth hormone replacement. This is usually successful in about 80% of the affected children. The therapy is ended when the growth rates are less than 1 inch per year. Usually at girls it's 14 years of age, and usually at boys it's 16 years of age. The optimum time to administer the growth hormone is at bedtime, because interestingly enough, the pituitary gland releases more growth hormone when the body is sleeping. So when the child is sleeping, usually it's in the first hour, I think 45 minutes to an hour, when they go to sleep, that's when the pituitary gland will release that growth hormone. And if we can give them a growth hormone supplement at that time, that will even more so enhance the growth hormone. So the care and management of the growth hormone deficiency, obviously, as I've talked about numerous times with the growth charts, are very, very important. And you can kind of watch the growth. If the growth has plateaued and there's reasons to believe that this child is not going to grow without the growth hormone replacement, then watching him grow on the chart is extremely important. And also, this is something that can be very devastating to the child. And, of course, children can be very mean, and they can make fun of the child who's not growing, who's short and not growing and not, looking like the other kids look. And so now the child is getting a growth hormone. And so it's very private, something very private, and you can help the parents understand that and deal with it as well as supporting the child. And again, preparation for testing and medication administration. The administration will be at bedtime. And you want to provide increased attention to the child during the testing time. The pituitary hyperfunction, this is excess growth hormone before closure of the epiphyseal shafts. It results in overgrowth of the long bones. And these patients, you've heard of people that can reach these astronomical heights. They can reach heights of 8 feet or more. They've just had more growth hormone during this time of growing before the growth plate closes. Usually the weight is generally in proportion to the height. And the hyperfunction, this is called acromegaly. And listed here on the slide, you see that the several facial features undergo overgrowth. And if you Google acromegaly, you'll see this. It's just a huge head, huge lips, tongue, jaw, noses. They look kind of freakish in a way, something that we're not used to seeing. Used to be very much related to circus people because they were so out of the norm. Very large people. And the diagnostic evaluation obviously is a history of excessive growth during childhood. Again, we look at the growth charts. Are they just huge? You know, they might have started out in a normal birth weight, but as they grow, and like I said, in the first year, usually we're charting, the charting of the growth is normal, but then they start to take off. And usually for the diagnostic purposes, yes, we can look at the lab studies or the blood work. We also look at the radiographic studies, and sometimes there's a tumor. Usually with acromegaly, there may be a tumor there. And then the management could be surgical treatment to remove the tumor if that's there. Once that's done, if it's thyroid related, they may have to have hormone replacement. So early identification of the children with excessive growth rates is huge. I mean, if you don't catch it by the time that those growth plates have closed, or by the time that they're done growing, then there's not a whole lot that can be done with it. And that's why we end up with adults that have acromegaly. But usually early treatment usually if we can get them early enough, then they'll have very good outcomes. Precocious puberty. This is defined as sexual development before age 9 in boys and before age 8 in girls. And a lot of times we see this, and if you're in adult children's doing your clinical or wherever you're doing your clinical and you have a developmentally delayed child, sometimes we see this in the developmentally delayed children where you'll see that they'll have breast buds, or you'll see that they'll have pubic hair or underarm hair, and you say, wow, you know, they're only 3 and 4 years old. And so this is something that's called precocious puberty, when they've started to develop. Usually there's a pathological cause, and it's usually disorder of gonads, adrenal glands, or hypothalamic pituitary gonadal axis. There's different types. Central precocious puberty, 80% of the cases are this. This is early maturation and development of gonads and secondary sex characteristics. And then there's peripheral precocious puberty, where there's premature development of breast, pubic and axillary hair, and menses. A lot of times the peripheral precocious puberty is the type that we see in the developmentally delayed. The treatment of specific cause, obviously if we know what has caused it, we'll treat that. And a lot of times the kids will go on Lupron, which slows down their prepubertal growth. And of course we need to educate the family on this, be very supportive, let them know what's going on, both the family and the child. Diabetes insipidus. Now this is different from diabetes mellitus. This is very, very different. So you have to separate the two. Diabetes insipidus is a principal disorder of the posterior pituitary gland. And what is diabetes mellitus? A disorder of the pancreas, or the production of insulin in the pancreas and the Iro-Langerhans cells. So it's two different things. Here we're talking about the pituitary gland. This results from hyposecretion of ADH, or antidiuretic hormone. It produces uncontrolled diuresis. Primary causes are usually familial or idiopathic. Secondary causes, and this is what we see a lot of the secondary causes: trauma, tumors, central nervous system infection, aneurysm. The cardinal signs of diabetes insipidus, or DI, is polyuria and polydipsia. Now we know that these are also the signs of diabetes mellitus, but again, don't confuse the two. DI is from the pituitary gland, DM is from the pancreas. But the cardinal signs for DI are polyuria and polydipsia. In infants, interesting, very interesting, and every now and then you'll see this. And usually in infants, irritability is relieved with feedings of water, but not milk. Dehydration then often occurs. So this is interesting because the baby's irritable and irritable and irritable, and you know, a lot of times we attribute this just to colic, but every now and then you'll get the mom that comes in because the moms will try everything to get their child or their baby to be very calm and not be so irritable. So in all that trial, they'll give them water, and water is the only thing that will satiate them, and because they are so thirsty because of the polydipsia. So you can give them milk and they won't be satiated, but you give them water. And when you hear that, that should be something, because even if the child does not have DI, they will not be calmed down by water. They actually want the milk. So if you hear that, say, you know, I gave my baby a bottle of water and he calmed down, he sucked a lot, he drank all that water, but he was so calm during that feeding. It's like, oh, or after that feeding, it's like, wow. So that should be a red flag. And then one of the ways to diagnose that is by reducing the fluid intake with little or no effect on the urine output. Therapeutic management, again, education. The parents, they hear diabetes, they think of diabetes mellitus. They think they're going to have to give their child insulin for the rest of their life. No, 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 no. You need to educate them on the difference between them. But yes, they will probably need a daily hormone replacement, and DDAVP is that replacement. SIADH, this is an oversecretion by the posterior pituitary gland, increased ADH, and it's characterized by fluid retention, hypotonicity. The kidneys are unable to reabsorb the water, and some of the outward symptoms are anorexia, nausea, vomiting, irritability, personality changes, and of course the symptoms are alleviated when the ADH is decreased. And how is this done? Well, there are medications on board. There are medications called ADH antagonizing medications that can be given to help with this. Okay, disorders of the thyroid function. The thyroid hormone regulates the basal metabolic rate. It secretes two hormones, the thyroid hormone, which consists of T4 and T3, and then calcitonin. Patients may have hypothyroidism or hyperthyroidism. Hypo meaning too little, hyper meaning too much. And usually they have the disturbance in the secretion of the TSH, the thyroid stimulating hormone. When we get thyroid blood panel, there's about, we get TSH, T4, T3, free T4, and calcitonin. And so there are several different markers that we look at. But the TSH is huge in that that's the thyroid stimulating hormone. So if it's not, if our body if our pituitary gland is secreting too much of the TSH, well, that's going to stimulate too much of the thyroid gland. If it's not stimulating enough thyroid, if it's low on the TSH, then it's not going to be stimulating the thyroid gland enough. Okay, so for juvenile hypothyroidism, next slide, it can be congenital or acquired, congenital hypoplastic thyroid gland. This is part of the newborn screening in Florida. They are screened for hypothyroidism. However, we know that even if the screening comes back okay, that means that there's no congenital hypothyroidism. But it can be developed down the road. So the next type is acquired, and the treatment for this would be partial or complete thyroidectomy for cancer or thyroid toxicosis. And then, of course, after radiation therapy for Hodgkin lymphoma or any malignancy. Okay, I just rewound that tape, so I'm just going to re-say this slide again. I'm not sure how much I got out of it, but anyway, for juvenile hypothyroidism, there's two types: congenital, which is found at birth. Florida does have newborn screening that includes screening for hypothyroidism or for thyroid issues. Then there's acquired that you can get down the road, and usually you get somebody would get this if they would have a partial or complete thyroidectomy for cancer or thyroid toxicosis. You can also get it after certain radiation on your thyroid gland for Hodgkin lymphoma or any other malignancy. To understand that rarely hypothyroidism would occur from dietary insufficiency in the United States. Okay, some clinical manifestations. So what we see if we have a low thyroid is mental decline, problems with memory, dizziness perhaps, not thinking clearly, your thoughts are all jumbo-mumboed. And so we can see that especially in adolescents or even any school-age kids. It's constipation. As a GI nurse, I always, whenever we have kids with ongoing constipation, one of the things we check for is their thyroid. We do check the TSH and usually the T4. Sleepiness, low energy, and some skin changes, dry skin. The hair becomes very sparse and brittle, and then puffiness around the eyes. And those are all indications that you don't have to have all of them. You don't have to have any of them, but those are just some indications that thyroid may be involved. And then, of course, if it's determined that your thyroid is low, there's oral thyroid hormone replacement. The sooner we can find this out, the better, because it is needed for brain growth, especially in infants. And of course, the compliance with the medication regime is crucial. And then we go to goiter, which is hypertrophy of the thyroid gland. Again, this can be congenital. It usually results from maternal ingestion of antithyroid drugs during pregnancy. And then it can be acquired, result of cancer, inflammatory disease, dietary deficiency, or increased secretion of pituitary thyrotropic hormone. Of course, goiter, a lot of times you can see it. You see the swelling of the neck because the thyroid gets bigger. The larger goiters may be obvious. Sometimes the parents will recognize it as the child swallows. They'll see a lump in the throat. And then sometimes on physical exam, if you're in the pediatrician's office, you can, or we as nurses do a little physical on them. You can feel it. When you do the physical on the thyroid glands, you can give them a glass of water and you kind of approach them from behind their neck so that your fingers meet at the esophagus or the trachea, and you can have them take water in their mouth, and then you just palpate the area around the trachea as they swallow, and you can feel the thyroid gland. Should be able to feel it, but small. Sometimes it's hard to feel. It's small, and that's a good thing. But the larger it is, or the more goiter that you have, the easier it is to feel. And usually immediate surgery may be life-saving in infants born with goiter, and sometimes that does happen. Lymphocytic thyroiditis. This is also known as Hashimoto's disease or autoimmune thyroiditis. This is the most common cause of thyroid disease in children and teenagers. It accounts for the largest percentage of juvenile hypothyroidism, and it usually occurs frequently after age 6 and then peaks during adolescence. Clinical manifestations include enlarged thyroid glands, usually firm, non-tender, freely movable. And again, if you feel the trachea, if you palpate the trachea, you see a kind of a fullness. Sometimes they'll complain of a fullness in their throat, not really difficulty swallowing or anything like that. It just feels full in there, hoarseness and dysphagia, and hyperthyroidism is possible. Goiter may be transient, asymptomatic. It may resolve spontaneously within 1 to 2 years. Sometimes oral thyroid hormone administration often decreases the goiter significantly, but usually surgery is contraindicated in this disorder. On to the next type of thyroid disease. It's Graves' disease. It constitutes the largest percentage of hyperthyroidism. It's believed to be caused by autoimmune response to the thyroid-stimulating hormone receptors. The signs include enlarged thyroid gland and exophthalmos. And if you've ever seen anybody with Graves' disease, the eyes are very large. If you think about Barbara Bush, our ex-president's wife, President Bush's wife, she had, you see her eyes, she's got Graves' disease, and her eyes just kind of pop out. That's a good example. The incident peaks between ages of 12 to 14 years, but the condition may be present at birth. And so then there's therapy. The goal of the therapy is to retard the rate of hormone secretion because it's hyperthyroidism. We're secreting too much of the thyroid gland. And I think it depends on the doctor that you go to and the training, and there are different treatments. There's medication, there's a subtotal thyroidectomy, and then there's iodine radiation that can help with it as well. Thyroid toxicosis is a thyroid crisis or storm. This may occur from sudden release of the hormone. It's unusual in children, but if it does happen, it can be life-threatening, and this may be precipitated by infection, surgery, or discontinuation of antithyroid therapy. And the treatment is antithyroid drugs or propranolol. So the management of hypothyroidism, we want to identify these children as soon as possible. Sometimes, before they actually get their thyroid up to secreting it good enough, they might need a quiet environment. They might need rest periods because obviously they get tired very quickly. They have no energy. You want to educate the parents on the dietary requirements to meet the child's increased metabolic rate. Seeing a nutritionist would be very good. And then, of course, if they have any side effects. And this actually should be care management for hyperthyroidism, I believe. So, okay, so now we're on to the parathyroid function. And so the parathyroid is actually a separate gland from the thyroid gland, and it secretes the parahormone, PTH. And the function is to maintain serum calcium level by a couple different ways. Increasing the release of calcium and phosphate from bone demineralization, increasing absorption of calcium and excretion of phosphate by the kidneys. It promotes calcium absorption in the GI tract. So hypoparathyroidism may be caused by a specific defect in the synthesis of PTH. May also occur secondary to other conditions, including infection. It could be part of autoimmune issues, post-operatively after the removal of your thyroid, and also conditions during the neonatal period, maternal hyperparathyroidism, maternal diabetes, we see that, and then formula with high phosphate to calcium ratio. Clinical manifestations of hypoparathyroidism is dry, scaly skin, brittle hair, thin nails with grooves in the nails. Now, obviously, this is kind of some issues with the other types of thyroid, hypothyroidism as well. So it, really, once you see these symptoms, then you have to kind of test further to determine, where is this coming from? Where is the lack or more of the hormone coming from? But headaches, seizures, emotional ability, depression, confusion, memory loss, all these are very similar. All these symptoms are very similar. Hyperparathyroidism, usually it's an adenoma or tumor of the gland. That's the primary. Secondary, we can see this with chronic renal disease, congenital anomalies of the urinary tract, and the common factor is too much calcium. This type is usually very rare in children. Not to spend a lot of time on it, But obviously there are blood studies to identify the increased calcium. Therapeutic management would be surgical removal if there is a tumor, or treat underlying cause. The biggest thing in this is the recognition of the disorder. Disorders of adrenal function. These are the adrenal glands. And the adrenal glands, or the adrenal cortex, secretes three groups of steroids. We have the glucocorticoids, which is cortisol, corticosteroid, mineralocorticoids, which is aldosterone, and sex steroids, which are androgens, estrogens, and progestins. And of course, the adrenal dysfunction is the altered levels of these produce the significant dysfunction. The disorders, so the adrenal medulla secretes the catecholamines, epinephrine and norepinephrine, and the catecholamine secreting tumors are the primary cause of the dysfunction. Acute adrenocortical insufficiency. Now, this is insufficiency, so they go into adrenal crisis. Usually the factors that started is a hemorrhage into the gland from trauma, fulminating infections, abrupt withdrawal of exogenous cortisone, meaning what? Meaning a child is on prednisone for some type of infection or inflammation, and all of a sudden they stop taking it. And so this is huge because we do have a lot of kids that we do put on prednisone. Prednisone is a very good drug to quickly help with infection or inflammation. And so we put them on it, and they can be on it for maybe a week or two. Now, studies have shown if they're on it for 3 or 4 days, then we don't have to worry about weaning. But if they are on it for longer than that, what happens is as you give exogenous prednisone or exogenous steroids, as you're taking them day by day, then the adrenal gland stops making that itself, stops making the glucocorticoids. So as it stops making that, because we're giving ourselves all these steroids, exogenous steroids, once we stop the exogenous steroids or the medication, then our body is not making anything. It takes a while to build that up, and we can go into crisis and go into adrenal crisis. So it's very important when the child is on some type of exogenous glucocorticoid, usually prednisone, whether it's IV or by the mouth, that once they've reached a place where their inflammation is cleared up and they're doing much better clinically, that they don't stop the steroid, that they do start a weaning process. So some clinical symptoms of insufficiency are increased irritability, headache, abdominal pain, nausea, vomiting, hyperpyrexia, cyanosis, seizures. The diagnosis is based on the clinical presentation. There isn't really any definitive test, but obviously if a child, we can get this information not only what the symptoms are, but what the history is as well. So chronic adrenocortical, this is chronic insufficiency. Another name for this is Addison's disease. And if any of you remember, and you're probably much too young, but know the history maybe behind it, President Kennedy, John F. Kennedy, he was a person who had Addison's disease. This is usually very rare in children. The causes, again, are infections, neoplasm, any autoimmune process, or it can be just idiopathic. The symptoms appear gradually after 90% of the adrenal tissue is non-functional. And this is a chronic disease. And basically the diagnosis is made on, we can measure the functional cortisol level reserve. And it's based on that. And then the therapeutic management would be replacement of the cortisol or aldosterone. Cushing syndrome. Think about when we think about Cushing syndrome, we kind of have a picture of that in our heads. And in fact, there is a picture in your book, if I can find it real quick. On page 1474, there's a picture of a child with Cushing's syndrome and kind of what the physical aspect of that would look like. And so when we have a patient that's on, and when we have we have a patient that's on steroids a long time, giving them exogenous steroids, like IV steroids or steroids by mouth. These are kind of the manifestations that are going to come out. This is what the child's going to look like. I don't know how many of you have ever seen a child that's been on long-term steroids or has had Cushing's syndrome. But usually we see, what's more frequent we see this is with a child has been on long-term steroids for kidney issues, for bowel issues, for lung issues, and they just get this, we call it Cushing-like effect. And basically they get what this child looks like in the picture. You get moon fascies where the face gets very large, kind of very puffy red cheeks. So they can bruise very easily, and they'll have some poor wound healing. Their wounds won't really heal, or their lesions won't really heal as quickly. They get a very pendulous abdomen, and they get striae as well because of the weight gain. And again, this can be caused by excessive or prolonged steroid therapy. For you, I've seen this on the hemonc floor, especially when they're undergoing chemotherapy or afterwards or prior to when they're on long-term steroids. Usually the condition is reversible once the steroids are discontinued, but remember, no abrupt withdrawal of the steroids. And the next slide kind of goes over the appearance that you see. The diagnostic evaluation of Cushing's disease. You measure the serum cortisol levels, imaging of the pituitary glands, skull films to examine the cella turcica, measurement of bone density, and then the laboratory testing. The management, depending on the cause, there can be some surgical intervention, replacement of the hormones, steroid administration early in the morning sometimes can delay that a little bit. Alternate day schedule possibly, just meaning that they won't get as much, and then postoperative complications if there are any. Congenital adrenal hyperplasia. This is the overproduction of adrenal androgens. It results in virilization of the female fetus, varying degrees of ambiguous genitalia, and salt wasting crisis frequently occurs. Therapeutic management of the congenital adrenal hyperplasia: administer glucocorticoids, diagnose and assign the sex to the child according to the genotype. So we had a child, or I've kind of been following a child since birth that has had congenital adrenal hyperplasia. A very interesting process, because they do have both sets of organs to some degree. To some degree there's a vagina, to some degree there's a penis, and so it's kind of interesting. They get their genotype, they actually get blood and get their genotype. What they're supposed to be is in their DNA, and they figure that out, and then they surgically correct them to that genotype. Usually reconstructive surgery is required. It depends to the degree that their sex organs are not developed. But usually reconstructive surgery is required. Not all cases are diagnosed at birth. It might be unless it's very overt, it might not be diagnosed at birth. And usually these individuals are not fertile. Pheochromocytoma is the adrenal tumor that secretes catecholamines. Again, the tumor is often bilateral, multiple, and benign. Clinical manifestations may mimic those of other disorders. Therapeutic management is usually surgical removal of the tumor or tumors. It may require both adrenal glands to be removed. It may require, both of the adrenal glands to be removed, and lifelong glucocorticoid or mineral corticoid therapy. Pancreatic hormone secretion. Okay, this is where the diabetes mellitus comes in. I know you guys have gone over this probably in your adult care. So just really quickly, as far as children go, this is the most common endocrine disorder of childhood. The peak incidence is between 10 and 15 years, and there's an increased risk for African American and Hispanic children. Type 1 is characterized by destruction of beta cells, usually leading to absolute insulin deficiency. The onset typically in childhood and adolescence, but can occur at any age, and most childhood cases of diabetes mellitus are type 1. Type 2 diabetes arises because of insulin resistance. It used to be that the onset was usually after age 5, but what are we seeing now? We're seeing that the children are at increased risk for type 2 because of their obesity, because of the prevalence of obesity. And usually these children are Native American, Hispanic, and African American children. Some of the affected people may require insulin injections. So the pathophysiology is with a deficiency of insulin, glucose is unable to enter the cell. It remains in the blood, causing hyperglycemia. When serum glucose exceeds the renal threshold, in other words, the kidneys can't get rid of it, the glucose spills into the urine, thus you have glycosuria. And the cells break down protein for conversion to glucose by the liver, glucogenesis. Ketoacidosis occurs when the glucose is unavailable for cellular metabolism. In other words, you need insulin to bind with the sugar to get into the cells. If you don't have the insulin to combine with the sugar, then the sugar can't get into the cells for energy. So it just sits in the bloodstream. And it just sits there and sits there. The body breaks down all the sources of energy. The ketones are then released and then into the urine, and then you have the ketonuria. You also get some of that into the lungs, and you have the acetone breath. So that, I don't know if you've ever smelled anybody's breath that has been in ketoacidosis, but it's very fruity smelling. It almost seems like they've been drinking alcohol. That kind of smells like that. Ketones in the blood are strong acids that lower serum pH and produce ketoacidosis. It can be a very dangerous state. It's considered a pediatric emergency. And usually the child is transferred to ICU and placed on an insulin drip and monitored very closely. So we all know the long-term complications of diabetes mellitus. I'm sure you've studied this in the adult world. The same for the child. And, especially we see a lot in your nephropathy and retinopathy and macrovascular disease. The earlier the child starts with this, the more chance that they have of, number one, not being compliant with their medication regimen, and therefore obtaining these complications a lot earlier. However, it has been shown that with excellent control that these complications can be delayed for about 20 years. So therapeutic management, there's a multidisciplinary approach. It's very much the same as in the adult world. Insulin therapy is usually needed. Monitor the glucose. They also monitor the measurement of the hemoglobin A1C, which is a measurement of their glucose over a period of 3 or 4 months. And if we can get that control, then it decreases the risk of long-term complications. Sometimes the issue is the selection of appropriate insulin preparation. There's lots of different insulins out there. Now we're seeing more and more insulin pumps. I see a lot of that with our patients that come into the clinic, the patients with a history of diabetes. A lot of the pediatric patients are on insulin pumps, which seems to provide a better control. The pump usually has the short-acting insulin in it, and depending on what they eat, they can give themselves a certain amount of insulin that will last for a couple hours. So it's very, very good. It's been researched and evidence that this is a very good way to control it. The patient has to be very compliant with it. I do see them starting younger and younger. When I was a school nurse in the schools, we used to see it when these pumps first became available for children. We used to see it more so in the school age, the older school age, and adolescence. And adolescence is even harder too because they're not very compliant at all with their diet, and therefore they have to be compliant with giving their insulin. But a lot of times the older school age kids are the ones that are mostly compliant. But as they get older, that declines. However, with good education can become good control. And I've actually seen children in kindergarten that have insulin pumps. I am so amazed by it. Sometimes I think that starting younger is even better, because the child doesn't know that much different. If the child is diagnosed at a younger age, then the parents have more control over that control for the child, that glucose control for the child, and then can teach them how to manage it and how to take control. The older, or the sooner that the child can take control and start managing their own disease, the better, because it is their body, it is their disease, it's something that they're going to have to deal with for the rest of their lives. And there might be some ups and downs, but that's how they learn. But again, I've seen a lot of the insulin pumps get put into place. Nutrition, exercise, measuring for hyperglycemia, illness management, all this is something that we as nurses can teach the families, can teach the parents, and therefore the patients. Very, very important, the education to these kids. Obviously, there's, even in the pediatric world, there is specialties. A nurse diabetic educator is huge. And usually most endocrinologists have those on staff, because they're the ones, and they're RNs, and they're the ones that work with the families and the children very close in understanding the disease process and how management can really affect the disease process. Patient education, as we've talked about, is huge. Blood sugar monitoring with the insulin pumps now, they can monitor their blood sugar. There might be new ones coming out in the market that can do that. Once in place can do the blood sugar, but the ones I have seen, you have to do an extra stick for the glucose. But there might be other ones on the market. I'm not 100% sure about that. But it's very good, and they should be able to monitor in the schools. Again, as a school nurse, and this was 10 years ago, we were very hesitant to get these kids in school, where they would, not hesitant to get them in school, but hesitant to have them monitor their blood sugar in the classroom. But I was always very pro getting these kids on board with managing their disease, and if that meant that they went to the bathroom, or they went to the nurse's office, or even had a little place in the back of the classroom where they kept their supplies locked up and just did it, because they just need to be in control of this. They don't need to abuse it, they just need to be in control of it. And I think school age is a really good age to start this at. If they have to start in adolescence, it might be more of a challenge for the nurse and for the family to get these kids on board. And this slide just shows the patient education that we have already discussed. And then the question for the last time, for the last slide, is a nasal spray of DDAVP is used to treat what? And I will let you guys answer that question.